A very warm welcome to everybody joining us this evening. It's great to have so many of you on the call today. And for those of you who I don't know or haven't met before, my name is Annie and I'm the support services officer here at Overcome. And I wanted to just take this opportunity to remind everybody that the Overcome support team are here to provide information and support to anyone affected by either ovarian cancer or borderline ovarian tumours too. And you can get in touch with us via our support line. You can send us an email, an instant chat message through our website. You can send us a message directly through our online forum, My Overcome, or even schedule a time to have an individual video call via Zoom or Skype if that works better for you. And the details of all of our support services are available on our website. I'll pop those in the chat very shortly, but we are here Monday to Friday, 10 AM to 5 PM to talk through any questions you may have, provide information resources, or just have a friendly chat. We're really happy always to hear from you, so please don't hesitate to get in touch with us if there's anything we may be able to help with, or any queries or thoughts that may arise from the webinar today. And I'm absolutely delighted to welcome Professor Mona El-Bahrawy, who will be presenting this evening's presentation. Professor El-Bahrawy is a professor of practice and a consultant histopathologist in the Department of Histopathology at Imperial College London at the Hammersmith campus. Today, Professor will be talking to us all about borderline ovarian tumours. And I'll hand over to you now, Professor El-Bahrawy. Thank you for joining us.
Thank you, Annie, for the introduction, and thank you, Alice, and everyone in the Overcome board for the honourable invitation. I'm most delighted to be here this evening with Overcome and everyone on board this evening. I've been working with Overcome since 2005 when I became a consultant histopathologist, and it's always a pleasure to be working with Overcome and everyone who sort of benefits from the great work they do. This evening I will be talking to you about a type of ovarian tumours which is called borderline ovarian tumours. And the aim of this talk is to address borderline ovarian tumours, or BOTS for short, describing what they are and why they are so called, give an overview of the principles of diagnosis and management of these tumours, and discuss the challenges faced by patients and doctors in the course of management of these tumours, and introduce some research initiatives that are ongoing or have been attempted to address some of these challenges. So going to basics, every living organism is made up of cells that come together to form tissues, and different tissues come together to form organs, and different organs come together to form organ systems that make up the whole organism. And that's for all living beings, if you will. And we're going to be looking at the female genital tract as an organ system, and this evening particularly we're interested in the ovary. So this is just a schematic representation of what the ovary looks like and where it sits in relation to other parts of the female genital tract. And then if we look at the ovary under the microscope, which is what I do in my day-to-day practice, we'll find that it's composed of different types of cells, which include what we call surface epithelial cells. And then you have the precious ova surrounded by other types of cells. And all of these are held together by what we call the stroma, composed of stromal cells. Now, like any other organ, every type of cell that is involved in the composition of any organ is capable of turning into a tumor, which may be a benign tumor and it may be a malignant tumor. we will talk about epithelial ovarian tumors this evening, and there are many theories about where they come from or where they start. One of them is that they start from the surface epithelium on the surface of the ovary. And this surface epithelium has got the ability to differentiate or develop into different shapes and forms. And we as histopathologists, according to the morphology of the different cell types, we give them names. So there may be serous, mucinous, endometrioid, clear cell, seromucinous, or Brenner, and sometimes you can find the epithelium in the same kind of focus, showing different types of cells and hence different types of differentiation. As I said, any type of epithelial cell can give rise to a tumor. And when we try to make the diagnosis of tumors, we have to include in our report the type of tumor. As to the cell type it is showing mostly, and decide whether it's a benign, borderline, or malignant. And if it's a malignant tumor, we have to give a tumor grade. And tumor grade basically means the extent of resemblance of the tumor cells to the original normal cells. And we also, for malignant tumors, give a tumor stage. And tumor stage means the extent of spread of the tumor in the body, which I will expand more in some of the coming slides. So going to tumor type, when we diagnose tumors and we want to classify them and give them the appropriate name, i.e. the final diagnosis, we use the WHO classification. And this slide just shows you the epithelial tumor classification. And as you see, it's a very long list. The highlighted in red is the different types of epithelium of which the tumor is composed. And you will notice that underneath every type, you have a benign variant, a malignant variant, and a borderline variant. And if we come to tumor grade, tumors in general are either graded according to a two-tier system, so type 1 and type 2. Type 1 is usually what we call low grade, and type 2 is high grade, that's in the ovary. Or you can have a 3 to 4 tier system where we call grade 1 well differentiated, that very much simulates the normal cells of origin. Grade 2 is moderately differentiated, 3 is poorly differentiated, and 4, if we use it, we refer to a very undifferentiated cell. It's the kind of cell or tumor that when we look at, it is not very telling what exactly it simulates. It has completely lost the resemblance to normal tissue. And so grade 1 is the lowest grade, and grade 3 or 4 are the highest grades. And for staging, we use for ovarian tumors the FIGO staging system, which is the one advised by the International Federation of Gynecology and Obstetrics. And for ovarian tumors, simply the staging is divided into 4 stages, where stage 1, the tumor is confined to the ovary or to both ovaries. Stage 2, when it starts spreading to adjacent pelvic organs and structures. Stage 3, if it extends further, going up into the abdominal cavity. And stage 4, if there is a distant metastasis beyond that. So what are borderline ovarian tumors? Why are they so called? So they are not benign tumors, and they are not malignant tumors either. They sit somewhere in between. And the reason for this is that they are usually tumors that show indolent clinical course, and they are cured by surgical removal, most of them, 85% of them. And this very much simulates what a benign tumor would do. But they also have a very low but definite potential to recur, spread beyond the ovary, and progress to full-blown malignancy. And this is like malignant tumors, but this is only seen in a small percentage of borderline ovarian tumors. And interestingly, this kind of progression or recurrence can be seen up to 20 years after the primary removal of the tumor. And these recurrences can occur in the remainder of the ovary, which hosted the original tumor. It can occur in the other ovary, and it can occur in extra ovarian sites. And the tumors have this diversity of biological behavior, and unfortunately, it cannot be predicted on histologic grounds. So when I look under the microscope, I may see a borderline that looks like this, or more complex like this, or even more complex and full like this, but there are no histological or molecular predictive features or markers that can tell us robustly how this tumor may behave. So this more simple looking tumor may behave aggressively, whereas this very busy, active looking tumor may behave in a very indolent manner and be completely cured after excision and never come back. But there are also variable follow-up protocols, which I will expand on in the following slides. And the other challenge with borderline ovarian tumors is that there are no effective therapeutic regimens for tumors that show progression or aggressive behavior. There is variability as to how these can be managed, and they do not respond to conventional therapy. So, for example, tumors that progress usually do not respond to chemotherapy as other, frankly, malignant tumors would. Borderline ovarian tumors account for 10 to 20% of all ovarian tumors. In the UK, we see about 600 newly diagnosed cases every year. They usually occur in women who are young in the fertility kind of stage of their life, median age 45, but 34% of these patients are under 40 years. Many of these ladies may well be keen to preserve fertility because they have not yet completed have had children or completed their family. So when I get a borderline ovarian tumor and I examine the tumor and we take samples from that we examine under the microscope, the first thing I want to do is to decide which type of differentiation it is. And the majority of borderline ovarian tumors that we see in our practice are of either serous borderline type or mucinous borderline type. The other types are extremely rare. I may see at most one a year in a tertiary referral center that I'm working in, or even less than that. We look then at features, most important of which is their invasion. If there is frank invasion, I look for that very diligently. And if I see what to me is defined as frank invasion, then I'm looking at a cancer. But if I see very limited sort of invasion, what we call micro invasion, and we measure that to the millimeter, and if it's still falling within the definition of microinvasion, then we call it a borderline ovarian tumor with microinvasion. So with any special features that may remotely hint at a potential for some aggressive behavior, we do record in our report so that our clinical colleagues are well aware of all the details of the features in the tumor and factor this in when they are making decisions as to how they will manage the case. We also look for other special features, one very significant one of which is micropapillary formation. And if it's florid, we call it a micropapillary variant of a serous borderline ovarian tumor. And the reason why we do take note of that is that these tumors that show this feature have sufficiently distinctive clinical and pathological features to warrant clear distinction from the typical or conventional type, if you will. They have an increased frequency of extending to the surface of the ovary, of existing in both ovaries at the same time, as being associated with extra ovarian deposits, and which equates an advanced stage, and they recur and disseminate at a frequency or to an extent that is very similar to frank ovarian carcinoma. The other thing we look at, because many times we have the primary ovarian tumor, and we also have samples from other parts like the omentum, the peritoneum, and we examine these very carefully, and we look for any extra ovarian deposits, which we call implants. And these are seen in about 20 to 30% of cases with serous borderline tumors. And when we find these extra ovarian deposits, we have to examine them very carefully, and there are features that warrant us classifying them as to either what is called a non-invasive, because they each give us a hint that this tumor may behave differently, significantly differently. And recently, we always used to call them non-invasive implants and invasive implants. Now, the consensus is if we see what we would have called an invasive implant, we now classify this as a low-grade serous carcinoma. So there may be a report where I have ovary with ovarian tumor and omentum, and in the ovary, I see a borderline ovarian tumor, and that will be my diagnosis. And in the omentum, I see deposits that I call low-grade serous carcinoma. Clinical colleagues can factor all of this in the decision for the management plan. In some cases, some surgeons prefer to do lymph node dissection, so removal of lymph nodes as well, that they believe may drain the regions of the tumor. And some deposits may be found in lymph nodes in 21 to 25% of cases that have undergone lymph node dissection. However, this is not a bad sign, and it does not at all mean that this tumor may be behaving in an aggressive manner. Most borderline ovarian tumors are operated on and diagnosed in community institutions or district general hospitals by generalists, and hence they may go to be reported by the pathologists in these hospitals. They can be very challenging tumors to diagnose, but this paper is not a recent one, but just to give you an idea about the extent of to which these tumors may be challenging to diagnose correctly. In a review of 477 ovarian tumors, 15% were reclassified from carcinoma to actually be borderline ovarian tumors, and 7% that were originally diagnosed as borderline ovarian tumors were actually reclassified by the specialist pathologists as borderline ovarian carcinomas. And an audit of 64 cases in one institution again reclassified 42% originally misdiagnosed as ovarian carcinoma and reclassified them as borderline ovarian tumors. Now there are reasons for that, which and it's you will find that they're more overdiagnosed than underdiagnosed actually. So like the pathologists may be preferring to sort of be more on the cautious side, and when they find it's a borderline ovarian tumor, it is then referred to a specialist center and hence reviewed by specialist pathologists to verify the diagnosis. There's also one thing that may add to this difficulty. Sometimes you have a benign tumor through and through, and only in a minor component you find features that you would very justifiably call borderline features. But the current consensus in the WHO classification is if you find these features of borderline change in approximately 10% or less of all the tissue you examine, then it would still be classified as a benign serous cystadenoma or a benign mucinous cystadenoma, hence a benign tumor. But we do mention the presence of the borderline focus, and we quantify it as being 10% or less. So again, the clinicians are aware of this, and it's up to them putting that in context with other features and deciding how they would wish to manage this tumor. So the conclusion that I would really like to put forward here is that all cases of diagnosed as borderline ovarian tumors should be referred to and discussed by a specialist gynecological oncology NDT, and the histopathology of these cases should be reported or reviewed by a specialist gynecological pathologist. These are uncommon tumors, as I have mentioned, and colleagues working in more peripheral centers, not working in oncology centers, may not be seeing enough of them continuously to be able to make well-informed conclusions about some of the cases which may prove to be really challenging and need a specialist workup. Moving on to staging. So, although borderline ovarian tumors are not classified as malignant, but we still do stage them as we would for malignant tumors. And we still do use the FIGO staging system for ovarian cancer. 70 to 80% of cases are diagnosed as an early stage, which is stage 1. So they are ovary confined, maybe to one ovary or to both ovaries. And tumors or cases presenting at stage 2 or 3 occur at nearly 21%, with less than 1% of patients presenting with stage 4 disease. When it comes to management of borderline ovarian tumors, there are many considerations that go beyond tumor stage and tumor type. So we factor in all parts of information we have for the clinicians to make the decision of management. So the principal way of managing borderline ovarian tumors is surgery for all cases. Any tumor that's suspected to be borderline has got to be surgically removed. But what needs discussion is the type and extent of surgical procedure, and the decision to which one to go for depends on the clinical examination, results of imaging, the size of the tumor, and indeed the patient's wish concerning future fertility, which is a very important matter in decision making of the management of these tumors, because, as I have mentioned, they may mainly almost commonly seen in women in the fertility stage. So radical surgery, or what we call non-fertility sparing, is a procedure where the patient or the surgeons remove the uterus, both fallopian tubes, both ovaries, together with the tumor. They do a mentum resection, they take peritoneal biopsies, some do lymph node dissection, and there is peritoneal wash. So there's complete removal of anything that may remotely harbor deposits, and definitely most of the organs this tumor may recur with, and this is radical non-fertility sparing surgery. And then for patients who prefer to preserve their fertility, we go for fertility sparing surgery, which may include just removing the tumor, which we call cystectomy, or removing one ovary that contained this tumor together with the tube, and leave behind the uterus and at least one ovary and fallopian tube. Now, recently, there is a technique that's very much employed for many cases in our center, which is ultrasound-guided ovarian wedge resection. So the surgeons use imaging intraoperatively and just remove the tumor with a wedge of ovarian tissue around it. And the value of this is that using imaging during surgery gives the surgeon better visualization and ability to detect even very small lesions. So it's a fantastic aid. It minimizes intraoperative complications because they just go straight to the tumor and the minimal tissue that they need to excise around it. And it helps them be more certain that they have completely removed the tumor with the rim of surrounding tissue and have not left anything behind. So it's an ancillary gadget, if you will, that helps the surgeon have more clarity intraoperatively. Now, what are the oncological outcomes of each choice of surgery? So the type of surgery performed, if you compare the oncological outcome of fertility sparing versus non-fertility sparing, there is a significant effect on recurrence. So patients who do non-fertility sparing surgery, who have everything removed, show a recurrence rate of 9.5%, whereas patients who undergo fertility sparing surgery may show a recurrence rate that ranges from 4.1% to 5.2%, depending on what sort of operation they had. But whatever operation they have for fertility sparing surgery, there isn't really a significant difference between different fertility sparing options, but there is indeed a very significant difference in likelihood of recurrence between radical and fertility sparing surgery. So the recurrences that occur following original surgery in either situation may be in the form of borderline ovarian tumor, or in some cases, the recurrence may actually represent low-grade carcinoma. So patients with borderline ovarian tumors need follow-up. Patients who have undergone radical surgery usually have follow-up of variable period, and in many institutions they stop having to have follow-up 5 years after original surgery. But patients who have opted for fertility sparing surgery will need to have follow-up continuously until they have completed the family size or have taken the decision that they are then ready to go for radical surgery and undergo completion surgery. But until they've had completion surgery, they have to be under very close follow-up protocols to ensure early detection and management of any recurrence as soon as possible. After fertility sparing surgery, the pregnancy outcome for patients is very encouraging, and most pregnancies occur spontaneously and as early as 3 months after surgery. The rate of spontaneous successful pregnancy is approximately 50%, and perhaps the main factor that limits fertility is the age of the patient. Also, the extent of surgery. So every time the patient has an ovarian surgery, it does have an impact on fertility and compromises it. So a patient who's had one surgical episode has a fertility level. If they undergo a second surgery to remove a recurrence, there is a second hit to the ovary, if you will, that can affect its structure and function and lower the chances of spontaneous fertility. Now, one relatively recently option to preserve fertility in young ladies is to have what is called oocyte cryopreservation, where the ovary is stimulated and then ova are collected and they are frozen indefinitely. And this may be an option for patients who feel that at the time of operation or following it, they are too young to have pregnancy, or who do not wish to conceive for whatever reason immediately after they have had their surgery. Now, obviously, everything may have its pros and cons. As you see from this image here, you hyperstimulate the ovary with hormones, and then ova are collected using a needle. And this can be a bit controversial because this is done before surgery, obviously, when the tumor is still in the body, and there is always the possibility that this may induce some spillage and spread of the tumor. So this has to be borne in mind in taking the decision. Having said that, it is still unclear if there is a potential impact for fertility drugs on the tumor progression. So the verdict is still not out on that, but in theory, it may have an impact, but this is not confirmed yet. Fertility preservation is a very important matter, and there are many considerations to have in mind. So fertility counseling should be preceded by a preoperative assessment of the ovarian reserve with a plan for post-operative monitoring. And fertility preservation may be contraindicated in some cases of recurrent tumors with high-risk features, or in case of a pre-existing low ovarian reserve. If the investigations show that this ovary has got very low reserve, the patient has to decide whether they want to take the risk of going for fertility-sparing surgery or not, based on this information. And the decision to perform fertility preservation should be taken on a case-by-case basis. There is no rule that fits all cases. And after assessing the risks and the benefits of existing procedures according to patients' preferences and overall assessment and circumstances. Right, let's shed some light on some aspects of borderline ovarian tumors and pregnancy. Now, with the advancing age of first pregnancy in many ladies now, and with the more thorough perinatal health care, the incidence and detection rates of ovarian tumors during pregnancy are also increasing. And the probability of discovering ovarian tumors during pregnancy is reported to be 0.2 to 10%, and among cases of pregnancy during which a tumor is identified, 8% of these tumors turn out to be borderline ovarian tumors. So what do you do when that happens? Some cases went for just watchful waiting until the patient delivered, and there are cases reported that borderline tumors diagnosed during pregnancy were surgically removed, as I will mention. We also have to be aware as pathologists, if this happens and the tumor is removed during pregnancy and it comes to us for diagnosis, because during pregnancy there are lots of hormones in the body, these hormones may potentially influence the morphology and the behavior of borderline ovarian tumors. And so when we receive them, we may find that the tumor is showing some more alarming features. We have to bear in mind and be informed by our clinical colleagues that this tumor was removed from a patient who was pregnant at the time. So we factor that into our assessment of the tumor and give some consideration that there may be a hormonal drive that making things look more worrying than they actually are. So a patient who had a borderline tumor before they were pregnant may, because of the changes in the whole environment, develop a recurrence during pregnancy. Therefore, if a patient has a previous history of a borderline ovarian tumor, subsequent pregnancy in itself may be a risk factor for recurrence, and even more careful follow-up during pregnancy is very much warranted. Because borderline ovarian tumors during pregnancy are rare, it's not a very common thing to encounter, there are no standardized treatment protocols in these situations. And again, the decision is taken by the clinicians on a case-by-case basis. And as I mentioned, there are reports of patients who were pregnant at the time of the second recurrence and underwent laparoscopic operations under general anesthesia at mid-pregnancy and continued to complete their pregnancy and have their baby very successfully delivered after surgery. So it is advisable, considering all of this, that pregnancy and delivery are both carried out at a tertiary center that has got gynecological oncology expertise to sort of handle the situation from beginning to end until the safe delivery of the baby. So I've shared with you a lot of information, but there is still a lot we need to know. We still need to work on finding markers that can help us identify which tumors have the potential to show aggressive behavior. And this is very important for us and for our clinical teams to develop a patient-tailored follow-up protocol. And we also need to identify therapeutic targets for patients who develop progressive disease, either in the form of recurring borderline tumors or progress to low-grade serous carcinoma. There are many studies that have addressed, published studies that have addressed these issues, but many of them have got their limitations. And these limitations are because of the rarity of the cases, particularly cases that show recurrence and progression. Now, luckily, they are a minority, but equally, this does not give us access to enough cases that have had events to be able to do large enough studies with enough statistical power to help us have very conclusive conclusions regarding to the correlations or what features would definitely indicate that this tumor may behave one way or another. Again, because of that, many of the studies have a retrospective rather than a prospective design. And the issue with that is that not everything is standardized in the cases that are included in the study, including the processing and the reporting of these tumors by the histopathologists. And even when we carry out molecular studies, we may not have thorough clinical and pathological data for all the cases to be able to do robust correlations and achieve very reliable conclusions. And finally, there is definitely a limitation of having studies on borderline ovarian tumors funded. If you do a literature search, say if you find 20,000 publications on ovarian cancer, you will find 2,000 on borderline ovarian tumors, which in fairness is proportionate perhaps to the incidence and also obviously the gravity or the seriousness of the disease. But nevertheless, it's a reality that we are hoping to sort of overcome and be able to have studies for borderline ovarian tumors having better chances of getting funded. I'll share with you some of the studies that we carried out within my research group. We had a multi-center national study that's just coming to conclusion in the next few weeks. It was labeled a thorough investigation towards developing a strategy for optimal care. And I can share with you that our aspiration to start with was to get cases from 40 oncology centres across the UK, and hopefully within the recruitment period, have about a cohort of 1,000 patients. We only managed to get over 100 because not all centres were willing to join us because we did not manage to get any funding for this. So every centre that sort of contributed to that was just doing it at their own expense and out of goodwill. And understandably, that was a great limitation. However, we still went on and did the study. And for this study, it was mainly prospective. We included patients who presented de novo with a new diagnosis of borderline ovarian tumors, or who have come back with a recent recurrence. And we had a standard protocol to review the histopathology of all these cases. And all these patients were followed up according to uniform protocol, annual clinical examination, and serum CA 1 to 5 assessment. And for patients who had opted for fertility sparing surgery, they had ultrasound examination during their follow-up visits annually. And from every case, we did collect a tissue block that would be available to use for molecular studies that we can then correlate with the uniformly collected clinical and pathological data. Now, what we have concluded from this study is that most borderline ovarian tumors present at an early stage, FIGO stage 1, which is in agreement with the current state of knowledge. And we found that patients presenting at a higher stage were mainly of an older age group than ladies presenting at stage 1 disease. We also found that serous and mucinous histological types are the most common, as in other cohorts. And we found that CA 1 to 5 is elevated not just at the first presentation, but also at recurrence, which consolidates the importance of having serum CA 1 to 5 assessed during the follow-up of patients, because it does it may quickly flag up the possibility that there may be a recurrence that may not be detectable on clinical examination or imaging readily. And we found that tumor recurrence was correlated to tumor type, being most commonly seen in serous tumors, and also correlated with advanced stage disease. In my lab, we also did several molecular studies on different cohorts, and you will see Overcome mentioned in the first study. I was very lucky to have this study funded by Overcome very long time ago now, over 10 years ago. And this is published, and of course, Overcome's contribution to that is very much appreciated and acknowledged. And we also went to look at the whole gene expression of benign, borderline, and low-grade serous tumors, and also looking at other genomic changes in comparing benign, borderline, and low-grade serous tumors. And the conclusion we got from the several studies was we identified a molecular subtypes of borderline ovarian tumors, where some tumors had a molecular signature similar to those seen in benign tumors, and some tumors showed a molecular signature similar to that seen in malignant tumors. And our current work is focusing to try to identify from these signatures some biomarkers that may be helpful in distinguishing which tumors may behave malignant-like and which may behave in a benign-like fashion, but this is still ongoing work that we are addressing. So in conclusion, borderline ovarian tumors represent a unique clinical entity characterized predominantly by favorable prognosis when diagnosed and managed in a timely manner. Fertility preservation options should be discussed in young women prior to surgery, with a borderline ovarian tumor being removed as soon as possible after they have completed childbearing. The optimal time for pregnancy is difficult to determine precisely, but it's very much advised that this decision is taken without delay so the patient can advance to having completion surgery as soon as possible to avoid or to avert the risk of recurrence. Again, I would like to say that these tumors require the involvement of a specialist clinical oncology multidisciplinary team in order to develop a tailored management plan on a case-by-case basis. In fact, in our centre, which is the West London Gynae Cancer Centre, based in Queen Charlotte and Chelsea, Hammersmith Hospital, we have got a specialist expert ovarian borderline tumour clinic, which is completely dedicated to the diagnosis and management of borderline ovarian tumours. And this is the Hammersmith Hospital where I have studied and worked for many years. And I would like to very much acknowledge all my colleagues at Imperial College London, and indeed in many institutions all over the world, who have supported our research activities, and the different funders who've also supported our work over the years. And finally, I would like to thank Overcome for this great opportunity of having me with you this evening. And I'm really delighted that you're all here. And thank you very much for listening.
Thank you ever so much, Professor El-Bahrawy, for your extremely informative and very comprehensive presentation. We're so grateful for your time and for sharing your expertise on this topic. And you very kindly agreed to answer some of the questions that have come through this evening, and people have been sending those in. Thank you to everyone who's sent those in. We will get to as many questions as we can, but as time, if we don't have time to get to everyone, Professor El-Bahrawy has very kindly offered to follow up on any of the unanswered questions via email. So we'll be sharing those with her in due course if we don't get to your question.
Sure.
Wonderful. So the first question we got in is someone who said, currently dealing with my third borderline recurrence since 2019. Are there any treatments other than surgery which can help prevent these recurrences?
As we stand, surgery is the principal option. But as I said, it's always assessed on a case-by-case basis. And it's very much worth it to discuss that with your oncologist. There may be an opportunity for some hormonal therapy, but treatment is not within my remit of expertise as a diagnostic histopathologist, but I answer that because sometimes we get asked to do some tests on the tumors to see whether they do express hormone receptors or not, in cases where the patient may potentially benefit from hormonal therapy, particularly if the recurrence has shown features of low-grade serous carcinoma rather than borderline ovarian tumor. So the nature of the recurrence needs to be assessed, and in the light of that, a discussion to be had with the oncologist to advise if surgery is the way forward or if there is surgery plus something else or something other than surgery recommended.
Thank you. Thank you very much. And the next question we've received, someone has said, "Hi, thank you so much for the talk. I had surgery to remove what was thought to be a simple cyst, but turned out to be a mucinous borderline ovarian tumour. Surgery was 6 months ago, and I now have another cyst on the same ovary. I have had a CT today. What is the likelihood this may be another borderline? What questions should I be asking my consultant to fully understand my options? My CA125 was normal, but more tumour markers have been tested. I would like to maintain my fertility as have not yet started a family, but I'm worried it may come back in the remaining ovary if they decide to remove the left one."
Right. Okay. Thank you very much for this question. Yes, sometimes we do get what was removed, thinking it's a simple cyst or a benign tumor, and then we find enough features to warrant diagnosis of a borderline ovarian tumor. Now, what is currently appearing to be a recurrence may well turn out to be part of this tumor or a new development, another cyst, if you will. So the possibilities are this is part of the original tumor, or a completely new tumor that was already there, but it was too small or not observed, and it has now become big enough to be identified on follow-up. Now, the options I think you may be offered by your treating surgeon is to have another resection of this newly identified lesion and leave the rest of the ovary behind, or have the whole ovary removed and just leave you the other ovary to keep your fertility. So I think what you need to do is have a discussion with your surgeon as to what all the options are that he or she thinks they would like to offer you, because the options they will offer you will depend on what is the exact details provided in the original histopathology report, the features identified by imaging of the current lesion, and all else in that is revealed by the clinical examination and the imaging. You say your CA1 to 5 was not raised. This is not a surprise, because CA1 to 5 may not be raised in cases of mucinous tumors. They are more likely to be raised in cases of serous borderline tumors. There are other tumor markers that may be raised with mucinous tumors, but not CA1 to 5. So that it is not against the diagnosis you received. As I say, in our center, our surgeons do offer the ultrasound guided wedge ovarian resection for recurrent cases, or even for primary cases where the lesion is small, aiming to leave as much ovarian tissue behind and with least traumatization to maintain fertility in this ovary for spontaneous pregnancy to the highest level.
Thank you very much, Professor. Thank you. And another question we've received, someone said, how long can people have borderline ovarian tumour for? Could they have it for 10 or 20 years without knowing?
The short answer is yes, because I suppose, like any lesion or a mass that's inside our body, it depends on its size. When we start noticing it, it depends on its location. So it may be small, but happens to sort of press on an important structure in our body. So we start feeling pain, feeling an obstruction of one thing or another. So yes, the short answer is yes. If it's not large enough, or if it's not symptomatic, it can stay in our body until the time when we notice it. And sometimes there are cases that are discovered during investigation for a completely different complaint. So patient may come with whatever, come to the hospital with whatever complaint that has nothing to do with her pelvis at all, but then in the course of the investigation or during the course of an operation, an ovarian cyst is noticed, and then they are referred to gynae for further exploration. And if this is excised, sometimes it turns out to be a borderline ovarian tumor.
Great. Thank you very much for that explanation. And someone said here, you've mentioned during your presentation about the role of CA125 in the diagnosis and follow-up of borderline ovarian tumours. Please, could you tell us a bit more about this, and would having a borderline ovarian tumour or low grade show up in any other blood work apart from CA125?
Right. Right. So I will not give you numbers because they vary, but obviously, like many of the chemicals in our blood, there's a range. Mm-hmm. And there are many reasons why CA125 can be raised in our bodies, and it's not necessarily because of a tumor. So there are other situations where CA125 can be raised. But once it's raised above the top of the range, if you will, this warrants investigation. And if the clinicians find an explanation to it that is not necessarily tumor, that's one thing, and the patient is managed accordingly. If a tumor is identified with a raised level of CA125, usually the decision is this tumor needs to be removed and examined, and then CA125 is tested right after surgery, and the expectation is that it will be noticed that it has dropped because the producing tumor has now been removed. And then the patient is followed up. And during follow-up visits, there is always monitoring by CA125. And as soon as this starts to rise again, this should warrant more thorough investigation to make sure that this rise is not caused by a recurrence. As to the other part of the question, there are other markers, and sometimes there are algorithms, so more than one marker, so CA125 plus other markers like one called HE4, and there are algorithms that factor in different markers, and the scoring of that can be sort of more indicative of the presence of an ovarian tumor. But currently, especially for the serous type, it's mainly CA125. Again, having said that, when a tumor is detected by clinical examination and by imaging, we usually do not know its exact type, a histological type, or whether or not it's benign, borderline, or malignant until it's surgically excised and we do the histological assessment. And that is why when there is an ovarian mass, the clinicians would order several tumor markers, not just CA125, because some other tumor subtypes, like for example the mucinous tumor, may give rise to another marker called CA199, for example. So usually the clinicians would request different tumor markers that may be elevated by different types of histological subtypes to help them know beforehand the possibility of what that may turn out to be, which again may influence their decision of what they remove during surgery.
Thank you, Professor. We've had another question come in. Someone has asked, how many other specialist histopathology centres like yours are there across the UK, England, Scotland, Wales and Northern Ireland, please?
There are at least 40, to my knowledge. There are at least 40. As you may know, for many years now, there has been more and more direction towards centralization of specialist oncology services and tertiary referral centres. So whether some of these have merged or newer ones developed, I haven't checked very recently, but there are around 40 to my knowledge.
Thank you, that's really helpful. And someone has asked, has NICE considered recommendations for a standard process for all patients? And I think that might be the time for the last question. I've just seen the time.
Okay, so it's not so much NICE, but there are organizations. So, for example, we have the British Association of Gynecological Cancer, and we have, and I'm privileged to be a member of a subgroup of the BGCS called the Guidelines subgroup. And in fact, we are, as we speak, working on an updated version for the guidelines for the management of ovarian tumors. And I'm involved in the writing of the chapter on borderline ovarian tumors. And within that, there are going to be guidelines as to the management. But as I say, I mean, these are guidelines, and centres in the UK are all considering these guidelines. But because of the, as I mentioned, these tumours being uncommon, and because of the variability of the preferences of the patients, there can be some diversity in the adoption of the guidelines. So there are guidelines, but there is some flexibility in their implementation between centres and between patients, depending on case-by-case basis. But there are unnegotiable things, if you will. So patients who have had fertility sparing surgery must be under stringent follow-up. Now, how frequent that is, the guidelines may say one thing, but the clinical team may find that this case, say the histology or the CA 1 to 5 or whatever, is showing some alarming features. Let's have more close follow-up for this patient, or otherwise.
Thank you, that's really helpful. Thank you very much. And we've come to the end of our time today. Thank you so much, Professor El-Bahrawy, for joining us, and for everybody who's taken the time on this chilly January evening to attend this webinar. We hope it's been really informative for you all. And as I mentioned earlier, Professor El-Bahrawy has really kindly offered to respond to the questions that we didn't have a chance to get to today, as we did have lots of questions coming through. So we will send out those to Professor and be circulating to everyone who's attended this evening in due course. And I just wanted to remind everybody who's attended to please get in touch with the support team if anyone has any questions, or they want to talk through anything, or they've got some queries about any of the content today. We've also got an information resource all about borderline ovarian tumours, which I will drop into the chat, which may be of interest to some of you. But again, a huge thank you to Professor El-Bahrawy for her time and expertise and energy this evening, and we look forward to welcoming you all to another event very soon.
Thank you very much. I really enjoyed being here and look forward to meeting you again. Thank you all for being here and for the invitation.
Brilliant. Thank you so much. Thank you, everyone. Bye.
Thanks. Bye.